I want you to imagine your pelvic floor. And instead of picturing it the way we usually do, as this static, bowl-shaped hammock.
Right, which is how every textbook draws it.
Exactly. I want you to picture a massive, heavy-duty canvas camping tent instead.
Oh, I like that analogy.
Yeah. So you've got this sturdy center pole, you've got thick canvas walls pulled really tight, and heavy-duty stakes anchored deep into the earth. And it is built to withstand an incredible amount of wind, rain, just daily stress.
It has to handle a lot of mechanical load.
Right. But what happens to that entire interconnected structure when a specific severe trauma rips those deep stakes right out of the ground?
Yeah, that's a big question.
Like a major childbirth tear, for example. Does the rest of the tent just miraculously stay up on its own, or does the whole structure become, fundamentally compromised?
Well, that structural question completely redefines how we view recovery from childbirth.
Hmm.
Because for decades, the medical community tended to treat injuries to the back passage and injuries to the vaginal canal as if they were in entirely separate zip codes.
Like they didn't affect each other at all.
Exactly. We looked at the surface damage without always considering the underlying foundation.
Right. And to answer that question today, we're not just looking at one viewpoint for this deep dive. We are cross-referencing global obstetric guidelines.
Specifically from the Royal College of Obstetricians and Gynecologists.
Yeah, the RCOG, as well as clinical care standards from Australia, and some really deep surgical playbooks on pelvic organ prolapse, plus some highly specialized anatomical research. We are pulling all these perspectives together for you.
Because when you combine the clinical guidelines with the raw biomechanics, you get a much clearer, frankly fascinating picture of the female body's engineering.
It really is incredible engineering. And our mission for you today is very specific. We are going straight into the hidden architecture of the pelvis to answer one crucial question. Can a third or fourth degree perineal tear affect vaginal support?
Yes.
Okay, let's unpack this, because I feel like before we can understand how a tear at the back ruins things at the front, we have to actually understand how the vagina is suspended in the first place.
Right. You really cannot grasp the collapse until you understand the construction.
Exactly.
And the gold standard for visualizing this construction comes from John O. Delancey's research. He completely revolutionized our understanding by defining pelvic support not as a bunch of isolated organs just sitting on a shelf, but as a fluid, interconnected suspension system made of 3 distinct levels.
Okay, so level 1, level 2, and level 3. Walk me through how these actually function.
Sure. Let's start at the very top. So
Yeah.
level 1 is your proximal suspension. These are your major suspension cables, specifically the uterosacral and cardinal ligaments. They attach the very top of the vagina and the uterus to the pelvic side walls and the sacrum.
So they're holding everything up.
Right. Their entire job is to hold the apex, the top of the structure, up against the downward pull of gravity. If level 1 fails, the roof basically caves in.
Okay, so going back to the tent, that's the center pole holding the highest point of the tent up. What's next?
Then we move down to level 2, which is the mid-vaginal support. And these are lateral attachments. You have the pubocervical fascia in the front and the rectovaginal fascia in the back.
Which is like connective tissue, right?
Exactly. Tough connective tissue. And they attach the sides of the vagina out to the pelvic walls. So if level 2 is compromised, the side walls cave in.
Got it.
And that's when you see a bulging of the bladder into the front wall, which is a cystocele, or a bulging of the rectum into the back wall, which is a rectocele.
Okay, so level 2, the side attachments, that's the canvas itself, pulled tight horizontally to give the tent its shape and keep the walls from blowing in. Which brings us to level 3.
Right. And level 3 is where the whole system anchors, the distal support.
Bottom.
Yes, at the very bottom. This consists of the connection of the vagina to the surrounding structures down there. Specifically, a dense knot of tissue called the perineal body and the urogenital diaphragm.
So level 3 is the stakes driven deep into the ground.
Exactly.
Because if you walk around and pull out those stakes, the center pole might still be standing, but the canvas goes slack. The whole tent loses its tension and just starts to flap in the wind. So is it fair to say the perineal body is essentially the ultimate stake in the ground?
That is a highly accurate way to look at it, yeah.
Yeah.
And what's fascinating here is how the muscles interact with that central stake.
Okay, how so?
Well, the levator muscles, which are a group of muscles including the puborectalis, pubococcygeus, and iliacoccygeus, they wrap around the pelvic organs and attach near this perineal body. They basically form a bowl at the bottom of the pelvis.
Yeah.
But It's not a closed bowl.
Right, because things have to get out.
Exactly. There is a physical gap in these muscles called the urogenital hiatus.
The urogenital hiatus.
Right. It's the opening that allows the urethra, the vagina, and the rectum to pass through. Now, to keep gravity from just pulling those organs right out through that gap, those levator muscles maintain a constant basal tone.
Wait, a constant basal tone? Do you mean like I'm flexing a muscle right now without even knowing it?
That is exactly what is happening, yes.
Wow.
Your brain is continuously sending low-level electrical signals to those muscles, telling them to maintain a gentle, continuous squeeze. You don't have to think about it. That squeeze keeps the hiatus closed and forms a solid shelf under the pelvic organs.
That is incredible. So whether you've had a baby, whether you're studying anatomy, or you're just intensely curious about human biomechanics, understanding this tent, the center pole, the tight canvas, and those deep stakes in the ground holding that muscle valve closed is the absolute key to everything else we are going to discuss today.
Definitely, because once you understand how the stakes hold the tension, you could understand the specific type of earthquake that rips them out.
Right. Let's talk about the earthquake.
Right.
We know the perineal body and those levator muscles are the foundation, level 3. Now we have to look at the clinical reality of what violently uproots them, which is obstetric anal sphincter injuries, or OASI.
Right. OASI encompasses the most severe lacerations that occur during vaginal childbirth. The global guidelines systematically classify these perineal tears into 4 degrees. And the distinction isn't just about pain or blood loss. It is entirely about structural depth.
Okay, so if a first or second degree tear involves tearing skin and muscle, why isn't the whole tent collapsing right then? What makes those relatively, safe structurally?
Well, it comes down to what is spared. A first-degree tear involves just the vaginal skin. A second-degree tear goes deeper into the perineal muscles and fascia. But crucially, in both first and second-degree tears, the damage stops before it reaches the anal sphincter complex.
Ah, okay. So the stakes are a little loose, maybe the ground shifted, but the anchor is still fundamentally in the dirt.
Exactly. The structural integrity holds. The real biomechanical threat begins at a third-degree tear, which is defined as a disruption that extends deep enough to physically tear the anal sphincter muscles.
Yikes.
Yeah, and the sources subdivide third-degree tears based on just how much of that vital muscle is destroyed.
Okay, break that down for me, because I saw the 3A, 3B, 3C classification in the RCOG guidelines, and I want to know the functional difference there.
Sure, so in a 3A tear, less than 50% of the thickness of the external anal sphincter is torn. In a 3B tear, more than 50% of that external sphincter is severed.
So the muscle you actively clench to hold in gas, that's the external one.
Yes, that's the voluntary muscle.
Oh.
But a 3C tear is where it gets structurally devastating.
Yeah.
A 3C tear goes completely through the external sphincter and severs the internal anal sphincter as well.
Oh, wow.
Yeah, and the internal sphincter is autonomic. You don't control it. It's what keeps you continent while you're sleeping. So losing both means losing both your manual backup and your automatic control.
That is rough. And then there's the 4th degree tear.
Right. The 4th degree is the absolute deepest. The tear shears completely through both the external and internal sphincters and breaches the anorectal mucosa, the actual lining of the bowel. You have a complete open communication between the outside environment and the inside of the rectum.
Wow. Okay, so as I was reading through the sources, there was one anomaly that honestly sounded terrifying: the rectal buttonhole.
Oh, yes.
Explain how this happens mechanically, because it sounds bizarre. How can a tear leave the sphincter perfectly intact but still cause massive structural failure?
The rectal buttonhole is a rare but highly treacherous injury. Think about the biomechanics of a baby's head descending. It acts like a localized battering ram against the posterior wall of the vagina.
Right, pushing backward.
Exactly.
Yeah.
In a buttonhole injury, the anal sphincter complex at the very bottom manages to stretch and survive intact. But the immense, localized pressure of the baby's head punches a hole directly through the tissue above the sphincter, right through the rectovaginal septum.
So you literally have a buttonhole connecting the vaginal canal and the rectal canal, but the exit door, the sphincter, is still closed.
Yes. And if a clinician misses it, it means wind and feces can pass directly from the rectum into the vagina, completely bypassing that intact sphincter.
Oh my God.
Yeah, it leads to a rectovaginal fistula.
Which makes total sense of why the diagnostic protocols in these guidelines are so incredibly strict.
All the sources are uncompromising on this. The guidelines state that all skin tears extending down to the anal margin must be treated as third-degree tears until proven otherwise by a senior, highly experienced obstetrician.
So you just assume the worst.
You have to. You simply cannot look at the surface skin and assume the underlying muscle is fine.
Because the surface might look like a simple second-degree tear, but underneath, the muscle has snapped, or there's a buttonhole hiding just an inch up.
Precisely. This is why a digital rectal examination is absolutely mandatory after every single vaginal birth.
Every single one.
Every
Wait.
single one. Even if the perineum appears completely intact to the naked eye, the clinician must physically insert a finger to assess the sphincter tone and feel the rectal mucosa to ensure there isn't a hidden defect.
Wow.
In fact, one of the sources highlighted a staggering statistic. Of women suffering from anal incontinence after childbirth, 50% were found to have had an incorrect initial assessment.
50%.
Yeah, a severe structural tear was simply missed.
Half of those women were sent home with the stakes of their tent completely uprooted, and nobody knew.
Exactly.
Which brings us directly to the core focus of this deep dive, the domino effect. We know the anatomy, we've defined the structural failure of the tears. How does this trauma at the back passage compromise the support of the vaginal canal?
It all circles back to that central anchor, the perineal body. When a third or fourth degree tear occurs, it doesn't just cut a muscle ring. It overstretches or completely cleaves the perineal body in half.
The ultimate stake in the ground is physically split.
Yes. And when the perineal body is split, the two halves of the perineal membrane actually drift apart. Because they are no longer anchored together in the tight center, the levator ani muscles, which remember attached to them, they also drift apart.
And those are the muscles that act as the foundational valve. So if they move apart, what happens to that urogenital hiatus, the physical gap?
Widens significantly, and that basal tone, that constant low-level squeeze holding everything up, is lost.
I see.
So the vaginal canal is suddenly sitting over a widened open gap. And because the floor is literally open, there is a massive unnatural downward stress placed on everything above it. The mid-vagina, the distal rectum, the normal angled axis of the vagina is completely altered.
Here's where it gets really interesting for you, connecting the dots on this engineering failure. By severing the perineal body, the upper levels, the uterus, the bladder, the mid-vagina, now have to carry their own weight against gravity because the tension below them is gone. The center pole might be okay, but the canvas is sagging under its own weight.
And that sagging directly leads to what clinicians call a low recticell. The rectal fascia separates from that damaged perineal body, creating a transverse defect.
So a weak spot.
Right. And without that support, the lower part of the rectum physically bulges forward, pushing into the back wall of the vagina.
I saw a term in the surgical text that described this, the eversion of the tissues. What does eversion actually mean in this context?
Eversion means the tissues are essentially turning inside out. Instead of a smooth canal, you have a physical bulge blocking the pathway. For the patient, this bulge acts as a roadblock for bowel movements. It traps stool, which aggravates constipation.
And if a patient is constipated, they push harder. The text mentioned they use a stronger Valsalva maneuver. Is that just the clinical term for bearing down and straining?
That's exactly it. The Valsalva maneuver is forcefully bearing down. But think about the physics here. When they bear down against that roadblock, they are putting immense downward pressure on a support system that has already lost its foundation. It forces the prolapse further down.
It's a vicious cycle. And I want you to consider the mechanical stress your pelvic floor is under just living a normal life. Coughing, laughing, sneezing, picking up a toddler. All of that requires those levator ani muscles to reflexively snap tight to prevent your organs from dropping. A severe tear short-circuits that reflex. The muscle is physically severed. It cannot pull taut.
Right. It is a profound loss of functional anatomy. The failure of level 3 support inherently drags down level 2, and eventually it threatens the apex at level 1.
So if the tent stakes are ripped out and the whole system is under constant gravitational stress, what is the blueprint for repair? How does a surgeon rebuild this structure while it is actively bearing weight?
Well, the clinical guidelines stress that the immediate response is everything. A third or fourth degree tear requires surgical repair in a fully equipped operating theater, not the delivery room.
Oh, wow. Okay.
And it's usually done under a regional anesthetic, like an epidural or even a general anesthetic.
Because it's not just a quick surface stitch.
Far from it. A highly trained clinician, so an experienced obstetrician or colorectal surgeon, has to physically locate the retracted ends of the sphincter muscle.
Wait, retracted, like a snapped rubber band pulling back into the tissue?
Precisely like a snapped rubber band.
Hmm.
They have to dig in, find those buried muscle ends, pull them back together, and correctly approximate them, either overlapping them or joining them end to end. And then they must meticulously rebuild that central perineal body to restore the anchor.
And the post-operative care sounded intense. This isn't just, take some ibuprofen and try to rest.
No, no. The structural repair must be protected from mechanical stress at all costs while it heals. Patients are usually given a urinary catheter initially,
Why a catheter?
so they don't have to physically get up and walk to the toilet, which puts downward pressure on the fresh stitches. They are also prescribed broad-spectrum antibiotics because the proximity to bowel flora makes infection a massive risk.
Yeah.
And an infection would literally dissolve the repair.
And they alter the diet entirely, right? The texts mention a low-residue diet and mandatory laxatives.
Yes. The goal for the first 10 days is to ensure that any bowel movements are incredibly soft. A hard stool passing through a newly repaired sphincter could stretch the muscle and literally tear the fresh sutures apart.
That sounds incredibly painful.
Plus, there's a strict protocol of no heavy lifting for 4 to 6 weeks.
But surgery is just fixing the hardware. I mean, the muscles have been severely traumatized. How do you fix the software?
That requires pelvic floor muscle training, or PFMT. Physiotherapy is non-negotiable.
Right.
The patient has to be taught how to correctly isolate and strengthen the anal sphincter and the levator muscles all over again. The whole goal of physiotherapy is to actively restore that vital basal tone, to keep the urogenital hiatus closed and prevent anal incontinence.
Which is the involuntary loss of wind or feces. Now, listening to all this, the snapping of the muscles, the widened hiatus, the sagging tent, the structural damage sounds devastating. But the sources actually offer a remarkably optimistic prognosis if the repair is done to protocol.
They do. The data is highly encouraging. If the tear is promptly identified and correctly repaired by a skilled clinician, 60 to 80% of women are completely asymptomatic at 12 months.
Wow.
Yeah, the tissues heal, the basal tone returns, and the foundation holds.
So what does this all mean for future pregnancies? Does a repaired third or fourth degree tear automatically mean a woman has to schedule a C-section next time? It seems like pushing another baby through that reconstructed stake would be a guaranteed disaster.
It's one of the most common concerns, for sure. But the guidelines clarify it is not an automatic C-section. There's a 7 to 10% chance of a repeat severe injury in a subsequent vaginal birth.
Okay, so it's a risk, but not a guarantee.
Right. If a woman has recovered well and has absolutely no symptoms, a future vaginal birth is generally considered safe.
But what if she is symptomatic? What if there's still some incontinence or, a feeling of heaviness?
If a patient is symptomatic, or if clinical tests show abnormal manometric pressures.
Hold on, manometric pressures. You mean literally measuring the physical pressure of how hard they can squeeze that muscle?
Yes, exactly. If the manometric pressures are low, indicating weak muscle force, or if an ultrasound shows lingering defects in the sphincter, then the structural integrity is compromised. In those cases, an elective cesarean is an option that should absolutely be offered and thoroughly discussed.
Okay. So, we started this deep dive with a very specific mission. We wanted to map the architecture to answer, can a third or fourth degree perineal tear affect vaginal support? And the answer, based on the anatomical physics and the clinical guidelines, is a resounding yes.
Unquestionably. The pelvic floor is an intricately interwoven fibromuscular web. Massive damage to the anal sphincter and the perineal body at the back directly and mechanically destabilizes the vaginal walls at the front.
You pull out the stakes, the tent sags.
Exactly. But if we connect this to the bigger picture, I want to leave you with one final lingering question that builds on what we've learned today about muscle tone and the nervous system.
Okay, I'm ready.
We know the levator ani muscles act like a continuous valve, and we know they rely on continuous electrical signals from the brain.
Right, the basal tone.
Well, the immense forces of childbirth don't just stretch muscle tissue. They profoundly stretch the S2 to S4 sacral nerves that power those muscles.
The actual electrical wires getting stretched out.
Right. This raises an important question. Could subclinical undiagnosed nerve damage during labor be the true hidden culprit behind prolapse symptoms that show up 10 or 20 years later?
Wait, really?
Yeah. What if a woman avoided a severe physical tear and her perineal body looks perfectly intact, but those sacral nerves were stretched just past their limit? Over a decade, that invisible nerve damage slowly degrades the basal muscle tone until the support finally fails.
That completely shifts the paradigm. It means the foundation isn't just about the physical canvas and the stakes, it's about the invisible electrical tension telling that whole tent to hold its shape. And when the current fades, well, the structure still falls.
Wow.
Thank you for joining us on this deep dive. Keep questioning the hidden mechanisms of the human body, whether it's the physics of a physical tear or the enviable firing of a stretched nerve. Because understanding the real engineering of how we are put together, knowing how the tension cables and the ground stakes actually work, is the best tool you have for advocating for your own health. Until next time.